Well, welcome everybody, and welcome to another episode of Mind Your Mouth podcast. I am your host, Melissa Mugnow, and as always, I am bringing you some amazing guests. Today is no different. We have Dr. Mike DeLuke, who's an orthodontist and is absolutely crushing it in the podcast game. If you are not following his content and watching him, then you are truly missing out if you are in the airway space. And we are so excited to have him on the pod today, just talking about all things where we're currently at in Airway and getting to know him a little bit more on a personal note. So, Dr. Mike, thanks so much for joining me again. It's so great to catch up with you. How are things going in the podcast world?
Really excited to be here with you. And yeah, it's been quite a journey. And I started this platform a few years ago, and then 2 years ago specifically started the podcast. It's really taken off since then. It actually was pretty cool. I got an alert the other day that about a week or so ago that I'm in 100 countries now with the show, which was pretty crazy to see. It's one of these things you probably find it too. You're sitting here behind the camera and you don't really know the impact that you have on the outside
Mhm.
world. I mean, people reach out to me and they will say things or comment, which is always nice. But I found that it lets me have much more, as you alluded to, authentic conversations with people that a lot of the public or my listening audience may know who they are, know of, but I get
Mhm.
to dive down a little deeper with them. And sometimes that's in an academic forum, sometimes that's just in a personal forum. And it really is fun. I'm really, really enjoying it. So thank you for having me on.
Yeah, as we were talking a little bit and even getting started, this podcast world is an interesting world. And it really is kind of I almost want to call it a little bit of a necessary evil. It's got so many pros and so many
Fair.
cons.
Yeah.
But, creating content and being able to have really great conversations I feel is really what's a driving force right now
Yeah.
in what's really helping this whole industry grow and this concept. And for some of you guys don't know, Dr. Mike had me on his podcast and it was really exciting. And I reached out to you because all of a sudden I just saw this content you were putting out and I was like, oh, this is awesome because you were having conversations with people that I would imagine if you and I were sitting at a restaurant or we went to a course, it felt like a conversation that maybe only a couple of your colleagues would maybe be privy to that information.
Hmm.
I was listening to you talk to someone and you were just like asking, you talking about lower expansion and, a little uncomfortable, but you were like, yeah, most of my colleagues would say no or
Hmm.
something like that. And I was really happy to just hear that conversation come onto a mainstream platform. So I guess kind of a lot of the people that I'm lucky enough that are maybe following me or leaning into the content is a lot of people that are curious about why is this not mainstream still? Why are people a little hesitant? Why is the ortho community still a little anti or I don't want to say they're as resistant as they used to be because I don't think that is 100% true.
Hmm.
So I think part of me was like, just curious where your head's at with that. I mean, you've had a lot of guests even since last time we spoke. Where is the temperature right now? Where are things at?
Yeah, it's an interesting question, and I would kind of agree and disagree with the lead in, which is it has progressed. I agree with you.
Okay.
Unfortunately, the people that are still really resistant are digging in even harder.
Ah, okay.
Right, so it's this sort of we've made a lot of progress, and actually, my talk that I'll be giving at Airway Palooza is going to talk a lot about the question you just asked, which is the state of this. And I'm going to, and that was a great question because you didn't even know that that was what I'm talking about. So kudos to you. It's good, great
Good,
interviewing.
good at least that my I have one tip, at least I have some idea what's going on.
No, that's great. As you were asking it, I'm like, wow, that's pretty cool. So, yeah, but I do have my finger on the pulse because as an orthodontist, as a board certified orthodontist, as an orthodontist who was in private practice for 2 decades and built and ran my own practice and saw and did just about everything you could see and do in those 20 years, and then or just 18 years, and then going into this arena, and I always was involved in academics, always from the beginning. Even when I built my practice in the early 2000s, I was driving back from upstate New York to Connecticut, where I was an orthodontic resident, or had been an orthodontic resident, to teach. And I was doing it twice a month, and then kind of once a month, and then 5, 6 years in, 7 years in, my practice started getting so busy I just couldn't do that. But I was also teaching at a general practice residency program in upstate New York, near where I was practicing. I ran the orthodontic part of the GPR, and I was the orthodontist on the cleft craniofacial team at Albany Medical Center in upstate New York for about 6, 7 years.
Oh,
So
cool.
I've seen a lot in the academic arena as well as in the private practice arena, which gives me a really unique perspective. Because
Mhm,
part of the problem here is the lack of communication and agreement between those two arenas. What I mean by that is the academic arena and even the traditional organizational arena, we'll call it, say, the AAO, right? American Association of Orthodontists. They have a much more traditional view of what orthodontics is and how orthodontics should be performed. Meaning, they still take a very tooth centered approach. They focus on treating, as I say, the symptom, which is the crowded teeth.
mhm,
And you might think, well, why? Like, there's so much evidence out there now to prove otherwise. And why don't they understand? And I'll get to in a second an issue with a recent editorial on mouth breathing that was in the AJODO, which is our main publication. So they seem to resist it very fervently, strongly. And they call me online, like when I'm in some of the ortho only study groups on Facebook. I mean, I get called a quack and a charlatan and a snake oil
mhm,
salesman all the time, right? All the time. And I can take it. I get it. But it's ramped up. It used to just be little grumblings, but as I've gotten more prominent and that message has gotten out there more, people start
mm,
really gunning for you. Yet on the flip side, I'm seeing way more younger docs, especially, but even middle aged docs, not as many older, some, but not as many, that are starting to open their minds to this. And that's been really encouraging. And I coach and train and teach young docs and residents around the country. And they're really understanding this at a new level. I think the whole Gen Z is really understanding the importance of being proactive in our health more.
mhm. I think they have a pretty big pulse in that, like, biohacking
Right.
movement, right, and taking a little bit more initiative, and I think they generally ask why a little bit more.
Right.
They don't just, like,
Agreed.
accept with whatever we say. So
Yep.
I think that is playing a little bit to our strengths. It's helping our cause a little bit, where I think a lot of our other colleagues, I don't know if you agree, like, don't really question it, just follow what we tell you to do, like,
Yep.
who are you, where that comes from. So I don't is that kinda where you're feeling that from, like, the different age groups of dentists that you're working with or talking to?
Completely. And one of the things that we were talking before we hopped on about my lecture at Panny, and I talk a lot about what I've termed orthodontics 2.0 versus orthodontics 3.0. And it's kind of an adaptation of Peter Attia from his book Outlive, where he talked about medicine 2.0 versus
Mhm.
3.0. And the 2.0 is the traditional reactive, right? You treat the disease, you treat the illness, you treat the problem. In the orthodontic world, that's malocclusion or poor growth and development versus the proactive of, well, maybe we can look at indicators younger, i.e., mouth breathing in our world, right?
Yeah.
Where maybe there's some things going on young that are kind of the canary in the coal mine here, where we could start to make decisions earlier. We're not saying we can solve every malocclusion with early treatment and myofunctional therapy in every 4 or 5 or 6 year old kid, right?
Mhm.
It's not what we're saying. What we're saying is if we have abnormalities such as that, we can do things to minimize the severity of that malocclusion and the problems they are going to have down the road. And that is a paradigm shift. That is a significant paradigm shift, meaning that mentality from reactive to proactive, whether it's medicine, dentistry, orthodontia specifically, isn't just a conceptual, well, maybe we could think about this a little differently. It's a fundamental paradigm shift. And why, right? Well, because when you go to school and you have all these years of being told the establishment in orthodontics, academia, the AAO, they have been down this path of us just being the best tooth straighteners for a long time.
Mhm.
And it's really, really hard to change for many reasons. One
Mm.
being, and I'm one of the few to call this out in the orthodontic arena, and I love my orthodontic colleagues. I love my profession. I'm fighting this fight to try to save the
I
orthodontic profession, not to hurt it.
just to go on that space, I think one thing you and I, when we talked last time on the podcast and you and I regularly with, like, somebody asked me recently, just on a podcast, they were like, "So how did you get into Myo?" I said, "It's always been about ortho for me. It's always been
Right.
about
I remember
ortho."
your story was awesome.
And
Yeah.
I said, "The goal is I sometimes just wanna look at my orthodontic friends and the colleagues, and I'm like, 'Why do you guys gotta make this so hard?' Like, we're not
Yeah.
trying to." But it's like if they agree to even, you know, jump on, or like that secret where they're like, Well, I agree a little bit just for this. It's like the white paper. Well, I'll agree that we can help, but we can't hurt. Or
Yeah.
so, they're
Yeah.
just used to having it one way. I think there's such a fear, like a fear-based and yeah, sorry, keep going. I don't mean to cut you off on that, but it's like it's almost a little frustrating because it's like, can you just let us help you help yourself?
Yeah, and I think there are a lot of reasons for that. You're exactly right. It is extremely frustrating, and not a day goes by that I don't face those frustrations and challenges. And so, as in this and through the podcast and talking to people and lecturing around the country and coaching people, I've really tried to dive deeper into why. Why is this happening? Kind of like why is the malocclusion happening? Is our profession so against this? And there's a couple things. Number one, fear, right? Fear of change. If you're
Mhm,
running a successful practice too, right? You've been doing this for a long time. When you're running a successful orthodontic practice, I'm not sure if your audience knows. I know you know from your experience, but you could be seeing 75, 100 patients a day.
mhm,
And now you're telling that person to do a more thorough evaluation and consultation process by a magnitude of maybe 5 or more times, meaning the average orthodontist, when I lecture, I'll ask people a lot of times in the room, and put your hand up. I'll call on you. Put out an answer of how many minutes you think the average orthodontist takes in the initial consultation. And it's typically anywhere from 1 to 5 that I hear back
mhm,
from everybody. And this is from doctors, whether they're orthodontists or non orthodontists, they're all dental professionals. And I would agree with that in having done this for many years and seeing many colleagues and how they practice. So you and I both know that in 1 to 5 minutes, you can't really dive deep enough into these other issues, especially remember, they're doing this a lot of times on, if they do it on a 7, 8-year-old child, they're literally just looking at, is this kid crowded? Am I going to have to pull teeth? And what can I do to maybe hold the space or preserve the space as much as possible to minimize the risk of pulling teeth? But it's probably going to need teeth pulled. I mean, that's really the discussion they're having in their head. Outside of if a patient has a crossbite or an anterior underbite, those are things most orthodontists are going to tackle young, not younger than probably 6 or 7, but at least
mhm.
that age. But when you have a patient who's just narrow, constricted arches, a lot of crowding, they're not looking at that patient as what could I do to grow and develop this face, or why is this patient like this? They're
Mm.
literally looking at how am I going to be able to fit these teeth in one day? That's what we're taught.
Yeah.
So, how do you change that mentality when they look quickly? Oh, nope, 8 millimeters of crowding. They're going to need teeth out. They're not set up to treat younger kids in their practice. They might not even have a CBCT or the diagnostic capabilities to really look into airway. Now you're telling them they have to coordinate care with a myofunctional therapist, an allergist, an otolaryngologist, right? Think of a tongue tie release provider. Think of
Mhm.
all the steps this takes. It's much easier to just put your fingers in your ears, la, 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 and I'm just going to keep straightening teeth because at the end of the day, that orthodontist is still helping that patient. We could argue about that, right? How much they're really helping. But at the end of the day, in their mind, they can easily put their head on the pillow at night and say, I made this kid look way better, right? I helped their
Well,
self esteem. They're not seeing the child 10 years later when that child has OSA at that point, right? They're not asking the questions about that child's behavior or sleep patterns in a young child. They're ignoring all of it.
well,
So,
and
right? So, I
doctor
mean,
and then just sorry, real quick, just for the listeners. And then in school, I mean, they're not just ignoring. I mean, this is truly what they spent hundreds of thousands of dollars to learn, get
fair.
trained on,
Yeah,
and we're told you're doing a great job. You're at one of the best programs. You're learning the top notch way, skills and techniques. So really they have no reason to believe that they're doing anything outside their obligation, their scope, and what their oath was.
right,
And I just said that to a group. I go, he doesn't think he's doing anything wrong because why he doesn't
right.
or she doesn't choose to hear it. And I love that you just brought up behavior management. I have a colleague here who said to me, Dr.
Yeah.
Barry Ray,
Yeah, Bear's on the
orthodontist.
show not not long ago. He's
Yeah.
amazing, yeah.
And look, you talked about quackery and stuff. I remember 12 years ago, literally standing at the New York Greater Dental Convention. Barry comes over. I'm sitting there talking to pediatric dentists out of Mount Sinai, like teaching at NYU.
Mhm.
Barry walks away and they go, that guy's nuts. Now later on, they said he just wouldn't give up. He kept pushing and
Yeah,
pushing. Long story short, I see a colleague now who took a course from Barry 10 years ago, pulls me aside and says, Melissa, if you tee these patients up, you serve them to me on a silver platter. There's no behavior modification that I have to do. He goes, I'll expand if you want me to I'll do it. He goes, "But I don't have the tools or the staff to support all the
There you go.
screaming and the crying,
There
all
you
of those
go.
things." He goes, "And I'm not gonna argue with the parents." He goes, "But if you send them to me, they'll sign away, they'll do all the work. I won't push back." And I was like, "Wow, that's a lot of pressure for all my therapists out
Yeah.
there," like, right? Because now I'm teaching them to, like, serve these patients like on a silver platter. But I do think the therapy community is willing to do the extra legwork. But this is actually a really amazing conversation. I think so many therapists feel like they're wrong. They don't want to be disrespectful. They don't want to do it. And I said, but sometimes you just gotta, you gotta, you gotta send it over there.
Yeah,
Um,
we're not set up for it. We're not taught it. I mean, most people don't realize that the vast majority of orthodontic residents in this country, so you go to school for most programs are 3 years now. I think there's a couple out there that may be 2, 2.5 years still, but most are 3. You are lucky if you're at a program that you treat more than 1 or 2 patients under the age of 10.
wow.
Ever.
Really?
Ever.
Wow.
Ever. And part of this, and I don't wanna get too much on a tangent, but it's relevant because in kind of the whole MAHA movement and trying to reform the system, we need to
Mhm.
reform the system that is the way orthodontics is paid
It's
for on a state level. Because what happens now is they use an index from the 1970s called the Saltzman Index. And that index, maybe the late 60s, I think it is, it actually looks at what's called a handicapping malocclusion. So a lot of these educational programs, they serve the underserved. They're located in areas where there is a higher population of underserved patients who cannot pay for private practitioners. So they are on state funding and they go to these educational institutions. And then that's where you're learning and seeing. So you're the preponderance of your patient percentage of your patients in most programs, again, not everyone, in most programs are not self-pay patients. So if they are going to get covered by Medicaid, they have to, in that state, every state's
Mhm.
rules are a little different, but most use this variation of this Saltzman index. They have to score, it's like 26 points or whatever it is. Well,
Mhm.
you don't count the baby teeth and you can't treat a patient who just has significant crowding and arch constriction, and they might have a caved in lower arch with a narrow maxilla. If they have a posterior crossbite, they will let you treat them with an expander. But if they don't have a posterior crossbite, those patients are going to be sent down a serial extraction pattern and they will pay for the teeth to be pulled, however many teeth need to be pulled at however many visits. They will then pay for the comprehensive orthodontics, which, having been a resident and taught in multiple residencies, sometimes goes on forever because you're not treating the problem. You're trying to straighten these teeth. You pulled teeth. It's a mess. The foundations are all off. The kid's growth was terrible. So you're treating these cases. I mean, it's not unreasonable for in some residencies for kids to be in treatment 3, 4, 5 years on the norm because this is how the system is built. I guarantee you, Melissa, if we could get change at the funding level to where they started funding proactive treatment in orthodontic residency training programs, you would see things change. And to that point, and then I want to hear your thoughts back on it. The AAO president was recently at the ADA airway meeting and publicly had said to a group of people, was asking about the problem in treating kids young. One of the, I say, highlighted that one of the problems of treating children young was you're going to use all their insurance benefit up in private practice. Yeah, because in
And this
private practice,
this was
you
just
won't.
in Chicago, right? This was just in Chicago.
Yeah, just in
Yeah.
Chicago. Yeah.
Uh-huh.
So that's the other side of the argument is that that's a private pay patient, not a state pay patient who won't get
Okay.
covered at all. But they, so
Mhm.
that's the, then you say, well, the private pays, well, why aren't they doing it? Because the orthodontist doesn't want to burn their benefit out and not be able to treat them when they're an adolescent. And that's straight out of the mouth of the AO president. So, and that is, I was not there. So that is hearsay, but I've heard from a couple people that comment was made. So if that's our mentality, right? It's hard
Mhm.
to change. It's hard to incorporate into our practices. We didn't learn it, as you said exactly. And there's no financial incentive to do it in residency programs, or it's actually restricted from doing it because those patients can't afford to self pay. So you have no other choice but to start extracting teeth. So that's how you learn to treat patients. And that's where does all the research come out of? the educational institutions. So why
Academia.
aren't our orthodontic programs doing any research on proactive care of young patients? Because they're not seeing any young patients. And if they are seeing them, the majority of them are on state funding and they have to take them down a serial extraction pathway. See how this
Which is
system is just totally
yeah.
fundamentally broken?
Well, I mean, and I think it kind of goes back to even a little bit of our conversation from on your podcast, just talking about the business of orthodontics, right? Like, and I'm always very open about it. Is that the right? Money's not a bad thing. Is a thing. We all need it to go around, but we are definitely not set up in general for a winning situation here for
Right.
anybody, and not for the orthodontist, the patient, the medical community, of the staff across the board. I mean, it's like anything, I think fear of change, but also fear of really unraveling a broken system
Right.
that when you unravel this, you sometimes got to tear some things down to rebuild it. And
Right.
it
Right.
is
Even if you
at
just
that
cleaning out your office, it looks worse before it looks better, right? If you clean your private office, right? You get papers piled and books and like when you start, you got stuff everywhere. You're like moving things and it looks worse, like a lot
well,
worse.
when you're under construction, it brings me back to the first time I ever really saw like a mentor, like I almost want to use the word scared, but like, when I see someone get defensive, it's
Mm,
usually hidden in fear, right? Like if I'm angry, it's because I'm scared. I'm scared of something. And I remember like when Invisalign was really pushing, I remember like a very polished, colleague, doctor, I mean, angry, like, "That doesn't work, that's ridiculous," like, you know what I mean? "That's
mhm,
BS, it's a fad," and then later on, obviously, we came into a situation where we started using it, but orthodontics in general, I feel as though has been under a microscope for a change has been inevitable for a very long, whether it was against clear aligners or change,
mhm.
like, there's all these different things, so I feel like as a community, there's a need to, like, hold on for dear like, and keep the values in the core instead of kind of naturally coming to the table and wanting to have these conversations of a way to do it better, because I look at it from outside. Again, I'm not an orthodontist. I just really believe I'm like a relative and I'm a family member. And I'm like, but you guys have this ability to like really come back into the healthcare community.
Yeah.
Like you guys get to really be doctors again. Like
Yeah.
and really treat humans and like
Right, not just
I
treat
one
teeth.
yeah, and, like, I'm like, "Do you understand as the engineer or the person that has the ability of, like, really changing the complete structure, you are so powerful in." I mean, like, I look at my son and the orthodontic aspect, if I didn't have that structural control, I'm helpless and
Mm,
hopeless to the outcome. I can only therapy so much, right?
right.
I can only therapy so much. I can only tongue click and breathe and all the things. You need to come in with structural
Structure.
component
Sure. Yeah.
without a doubt. And I think there's that tug and pull of like, it's like, I don't want you to choose. I want you to do both, right? Like, I want you to have the therapy and I want you expansions. I want all of it.
Right, which is why I think again the younger docs are more receptive to it because there does seem to be in this new generation a bigger push for the why, as you alluded to before, the cause, the holistic nature of it. In the older generation, remember, if you're running one of these practices, and I ran one and I had to do this, so I'm able to speak to this with a pretty good level of personal experience because I was running a practice that was going a million miles an hour and I had to transform how I did this. I had to bring in and invest in an iCAD. I decided to do that. But once I brought it in, I had to figure out how to implement it. This is over 10 years ago and start to understand how to implement this additional diagnostic information and how to communicate with my medical colleagues. This is again 2014 when I put my iCAD in. None of this was out there. People weren't talking about it. You couldn't listen to a podcast on it or go find courses on YouTube. So I had to figure that part out. And Melissa, it's really hard to implement it. When you have a practice that's going very quickly and is very lucrative, it can be a financial disincentive at first. And people don't want to talk about that. They get really uncomfortable. In fact, I find the gaslighting on that is obnoxious because what people who don't want to do this and be more proactive say is, you're just doing it for the money. Oh, you're just treating early because you want to build these patients twice and do it for the money. Well, You ask anybody who goes down this path, whether they're an orthodontist or non-orthodontist in the dental profession, when you start doing this, it is not as profitable as what you were doing. You can make a lot of money and straight it just being a good tooth straightener. So
I actually
why do you
yeah,
want to stop that? Learn,
I
expand your
think it's the
clinic, right?
opposite.
Have younger kids in your clinic, deal with the parents, deal with all these other problems, invest in different technology, invest in different techniques, retrain your team, re-communicate to your parents and the people in your community how you approach cases, and potentially take a financial hit for a period of time until you can figure out how to get those systems built. I mean,
Yeah,
really, like, I'm not being that's not
no,
a tongue in cheek question. I'm being serious, and it's not even rhetorical. What is the
why?
incentive for a
Yeah.
busy practitioner
Well,
to do that?
I think both, like, from a coaching aspect, from another, I find, like, we really as a team from a consulting aspect, we finally, like, really got some docs to be really open and allow us to share with numbers. 2.5 years from their airway side before they even hit black, like, even were
Got
slightly
back.
into black, right?
Yeah, yeah,
And I mean, we did a real true time audit, more staff, more education, all
yes,
this light scalpel, on it, all the different courses, all of that. Thank gosh they had the other side of the practice and, and we talked about this. They said the best advice I heard was, "This is a startup business. Don't act like it's part of your dental practice, and it's
yeah,
gotta be a bit of a passion project."
yeah.
Well,
That's
you're
a good
right.
point. Passion project. Yeah,
Yeah, there is this is absolutely not about the money. I think you're really hitting some really great points. These are massive pain points for some of these docs that are I mean, listen, you guys are in debt, you got all this, and then you guys all have the audacity to get married, have a couple kids,
right. Right.
you
And if you go work for someone
snackle.
else, how do you change? I mean, that's the other thing I want your audience to understand is like I walked out and I started my own practice day one. So I could do whatever I wanted. I never had a boss. I never had anybody tell me what I couldn't do, use techniques, technologies. That is not the case for everybody. Most people, especially as you said, with all the debt that, I mean, the average debt right now coming out, I just saw a statistic, it's $567,000 per doctor when you graduate as an orthodontist. So it's real, it's a lot of money, and they have to start paying that back. And as you also said, they want to start having a family and have a house and all of those things to start their lives. Because usually by the time you get through all the schooling, you're 30 or young in your young 30s typically. So they've sacrificed a lot. They want to start their lives and they go into a practice with a senior doc or docs or a corporate. You're telling me you're going to get them, you're going to walk in as a new hotshot off the street and have them change the entire way they run that practice? You'll be out of a
Not a
job.
yeah,
You're gonna get fired. I wouldn't have wanted someone to come into my practice and tell me how to run it. So it's not that your input is invalid, but you're going to change all their systems. It's not going to happen. So I think these are the conversations that are, again, to your initial question, which it was so appropriate because I've been spending so much time thinking about this with what I'm going to be talking about in October at Airway-Palooza, that it's like, you know what? This is big. This is really, really big. This is not just like, why won't these stubborn orthodontists just wake up and realize this is a thing? And in fairness, I used to think that too about my colleagues. Like, why are they doing this? Why aren't they doing this? And then I started digging deeper and talking to more people and realizing it's not a light switch. You can't just do it. And the last thing I'll say on that is, in our conversation on my show and with your son, I'm sure you agree, but a lot of the people that do want to go all in on this and are willing to take all the hits we just talked about taking,
mhm.
it's because they recognized it in their own child
Yes,
more
it's
times than not.
personal.
It's
Mhm.
personal on some level, right? Or child
Yeah,
or niece or
yeah,
nephew
family
or
member, yeah,
grandchild,
somebody.
it's
Mhm.
personal at some level. It's not 100%, but it's the vast majority that that's the case, right?
Well, you don't really get people to make it you like, from a human behavioral concept, you don't really get someone to change unless you make them feel something or you educate them on a level it's just undeniable that they
Right.
can't see it, right? And I think there is a lot of education out there. I think if we put all, if we were one-on-one in a room with most of our colleagues, they're not gonna deny what we're saying. I mean, we make the joke, we all took the same anatomy class. We're not denying that muscles have an impact. We just want to hopefully kind of deny how much of an impact that they have and hope that the
Mhm.
current methodology has enough force that it can withstand and hopefully some of this isn't all that true. But when you feel it on that personal side, it's undeniable and you want to do more, which I think if you're okay with that, a little bit of a, in the same realm, but like, what do you do? What is some of the options? What are you seeing from your coaching practice that you're able to support some of these docs to help them get into it a little bit more? Are there any tricks or tips that you've
Mm.
been utilizing?
So it's kind of different depending on who I'm coaching or who I'm trying to help. Some people, it is getting them to understand what this even is, right? What
Mhm.
this is, and they kind of have a feel for it, a little bit of feel. Maybe they don't have that personal experience, that visceral gut instinct to do this because of their personal experiences, but they're realizing there's something to this, and they're smart and educated and they want to learn more. And there's some people who come that are all in, want to do this. They know it's the right thing to do. They just don't know how to do it. And that's the other thing, is we don't learn how to do this. And what I mean by this is even just treat younger kids or expand in the absence of a crossbite. We're taught you don't do that. And that's insane to me, because I always give the example of patient A and patient B, and what the patient A and patient B walk into an orthodontic office, right? And sadly, this isn't a joke. This is the way this is approached in our profession. If patient A comes in with size maxilla of a given width, and they have a posterior crossbite, we'll call it bilateral to avoid any conversations of a shift. So they have a bilateral posterior crossbite, which means the maxilla is narrow, right? And the mandibular arch, the teeth are upright, straight over the bone, no excessive curve of Wilson, no steep, no impingement on the tongue space, nice, beautiful, broad mandibular arch, narrow maxilla, bilateral crossbite. Okay. Now we take patient B, walks into the orthodontic office. Something you see all the time, patient A and patient B. Every day in practice, you'll see this. Same exact maxilla as patient A. Identical, identical. The lower arch, instead of those teeth being in bilateral crossbite and upright, they're caved in, those teeth. Okay.
Mhm.
So the teeth are caved in toward the tongue, not a lot of tongue space. So that patient not only has a narrow maxilla with crowding in the upper arch, they have a very narrow mandibular arch to compensate to that narrow maxilla, with a lot of lower crowding and a lot of other compensations with all those teeth caved in. If you ask vast majority of orthodontists out there, and especially like directors of programs and in academia, they would say you treat patient A all day by expanding that patient's maxilla. You
Mhm.
do not touch patient B. And if patient B ends up having crowding problems, let's say this patient, I should have said before, but let's say it's like a 6-year-old or a 7-year-old. If patient B ends up having crowding problems later, you extract teeth on patient B. You don't expand them, because, Melissa, you don't expand in the absence of a crossbite in this mentality. And when I say this to them, I have challenged people at academic levels, at administrative levels within the AAO, and said, explain to me the logic in that. Because if you ask just anybody off the street, a layperson, and you explain it, and in my lectures when I teach, I have a schematic I've built with like moving the teeth and showing this. How could you reconcile that patient B doesn't have a problem in two arches and patient A only has a problem in one arch?
Yeah. Yeah.
Right? I mean, it's not really hard to make that argument. Like, they both have the same maxilla, narrow and constricted and crowded arch. A has a normal mandibular arch. B has a caved in one. Like, not rocket science here. Yet I have been told that it is malpractice to expand a child with primary teeth in the mandibular arch, and that I should have my ABO certification revoked for doing it, for treating
Okay.
patient B.
And just for the
And that
lay
was
just
actually recently that I was told that. So,
just for the lays person, if we happen to be catching some parents that are listening in, is this because the philosophy is that you cannot grow the bone or cannot expand the lower mandible, you only can do the upper?
right. And so I say to them, who said anything about expanding the mandible? Like, I'm not even saying you need to expand the mandible. Remember, in patient B, the bone was plenty wide, the teeth were just caved in to meet the narrow maxilla, right?
Because just for and this is a really amazing point, I love this, right? Because a lot of cases, even if we're using, there's all these people with prefabricated, whatever, a lot of times just giving support to the lower anteriors or the lower teeth, right? The maxilla, and just getting them upright
Yep.
and then expanding the upper
Yep.
will allow for growth, right? If the
Yes.
child is still in a growing, time. I'm not talking about a 14 or a 15-year-old or a 16-year, right? We're
Correct.
talking
Right.
in these younger ages,
Yep.
but they'll say, nope, just leave it alone. Don't do anything,
Yes.
which is crazy.
And let me take it a step further. When you get that, anybody listening to, I want you to challenge your orthodontists. Say, "Oh, okay, then why don't we take patient A and treat that patient instead of expanding their maxilla, we should just treat them by caving the lower arch in."
Yeah. Well, and what would they that's
Well,
nuts.
they don't answer me. They literally gaslight and sidetrack and go into some other discussion on how you can't expand a mandible. And I'm like, I get it. The mandibular symphysis is fused around birth. Conceded, point conceded. You would need distraction osteogenesis and a midline symphysial cut to be able to expand a mandible. And you can do that in certain patients with craniofacial anomalies. Not talking about that. I'm talking about a patient with a normal sized mandible, but a narrow, restricted, caved in mandibular arch. So you would never see an orthodontist. I hate to use the word never, but I honestly think never that you would take patient A and they would be like, "Oh, we're treating that lower to cave that in because that
Mhm.
you know that lower's got to meet that upper." No, they expand the upper. So why would you not address the issue in B? You can't answer. It's not actually something from a scientific perspective they could answer it. They just say things like, "Well, it's never been done," or "There's no data," or "It's not evidence
Yeah.
based."
No
No,
reason.
there's tons of research on expansion of the mandibular arch. Tons of research out there on it. And there's, I mean, when you talk about McNamara had a study that he put out in 2006, I believe it was. Yeah, 2006. And they looked at basically what they did is they looked at three subsets of patients, and one had no treatment, one had just upper expansion, and none of these patients had posterior crossbites, and one had expansion in the both upper and the lower. And they actually found, and he has a great article in 2000 that talks about this exact thing. James McNamara is a huge name in our field, and he talks
Yeah.
about this exact thing. The title of that article is called Maxillary Transverse Deficiency, and he calls patient B in our example that he calls it occult transverse deficiency and an occult maxillary transverse deficiency. And he said it is the most underdetected, underdiagnosed malocclusion in orthodontia. So, and McNamara, again, he's not
Wow.
fringe. He's a huge name in our field. But in the '06 article with, it was Garin, Bichetti, and I'm trying to think of the exact people he was with on that one, but it'll come to me. But so basically the concept is what he did is he looked at these subsets of patients and he followed them over, I think it was 20 years at four different time points. Let's see. Anyway, it's going to bother me. I think O'Grady, Bichetti, and Frankie. That's what it was, McNamara. So we looked at these patients and they started at 9, which is even kind of late considering. And the four time points were pre-treatment, post-treatment, retention, and then 20 years later. Okay. And what they found was, and I mean, it's going to blow your mind because this was in the AJODO, our main or less than 20
Yeah.
years ago, that the patients who had upper and lower expansion had more favorable results than the upper expansion alone group, including greater arch perimeter, right? Greater normalization of the transverse dimension, and the uprighting of those lower teeth allowed you to increase the amount of lower expansion, which then allowed you to increase the amount of upper expansion, and in the end, those patients had superior results even 20 years out. Uh,
Wow.
we don't
And
talk about, I'm like, this is published in the AJODO 2006. I don't get it. Why we act like this is, and you're going to tell me I should have my board certification taken away
argue
because I'm
way.
doing that. But then you tell me it's not evidence based. But then I give you evidence basis and you tell me you don't agree with it. I mean, you see what I'm saying? You're like, where are we? That's why when that sort of thing happens, that tells me that you're over the target and that now people are uncomfortable to change. It's not about
Mhm.
science anymore. It's not about data anymore. It's
Yep.
about, right? It's about
Status
discomfort to
quo.
change. Yeah,
Status quo. Yeah.
completely. Yeah.
And, I try to keep in a spirit, in a spiritual mindset of positive and recognize sometimes things have to get really uncomfortable before you can truly have change or before like a major breakthrough. And I try to stay in that space of like anytime I get really frustrated, I try to remember where we were to where we are.
Yep.
And I do feel like, I do see more, and maybe it's because I try to focus on it. I try to say, "Okay, I see more people talking about it. People are pulling me aside and asking." And I am curious more if you are, people that may be on the front. Well, it sounds like you are in a position right now that you've been getting some pretty heavy pushback, right? Right? Are you feeling
Oh
like
yeah. Yeah.
yeah, so you're like in the thick of it right now.
I
Or
not even right. I mean, I've been in the
you've
past
been.
couple of years. Yeah. I've had to shoulder a lot of this fight, and don't call it a burden because it's not a burden. I actually I take it willingly. I put myself in this position willingly and knowingly that this is what's going to come for me. But I So I've spent a lot of time doing research of the research and the data. And I'm going to be formulating a rebuttal that I'm working on with other colleagues to the article that I referenced before and earlier in the show about that was in the AJODO talking about how mouth breathing is not really a big deal. And you can't quantify mouth breathing and you can't figure mouth breathing out. And there's no real way to determine if it's a thing or not a thing. I mean, this is all things that were said in this, saying that the Harvard studies, which are landmark studies, were completely invalid. And I mean, just, and then people have been putting it around who are of that mindset, like, this is great. This is great. Melissa, it's an opinion piece. It's an editorial. He literally just gave a bunch of his own opinions on this topic. And the references he quoted were very, very poorly done. So it needs to be torn apart and it needs to be addressed. And I was flattered to have a bunch of people reach out to me and say, like, hey, you should
Can you do
debunk this.
this? Yeah.
Can you do it? And so I'm working on that because that's what we have to start to do. And I'm not doing it to try to convince that. This is the other thing that's important, I think, for your audience to hear. When I'm passionate about this and I'm talking about it, I'm not expecting that author is ever going to change his mind, ever. Right. Sadly, in the beginning of it, he actually said he was asked to write this, which tells
Mm.
me the editor went to him and said, can you shut all these people talking about mouth breathing and this whole thing about airway being important? Can you shut them up? And he's a respected name in the field. So he writes, by some, I suppose, he writes this editorial as kind of a hit piece. And so it's not to change his mind. I honestly don't think or know if I ever would. It's that all the people who saw it, and then I know in multiple residency programs, directors who don't want their residents to be thinking the way you think or I think, use that to show all the residents, see, look, this whole mouth breathing thing that these people are talking about is crazy. You just stay with us in the way we're teaching you these things. And Melissa, the article is actually terribly written. I've torn it apart and breaking it down to rebut it, and it's really poorly done. So they say they want evidence based. They say they want randomized controlled trials, which doesn't define evidence basis anyway for everything. Yet they use this opinion piece as the landmark document now to to try to refute that we should talk about mouth breathing and try to detect it in our young patients because it just may impact the way they grow. It's
Mhm.
hard to comprehend, but yeah, it's pretty deep. So yeah, I have had the responsibility to fight this head on,
And
and I don't mind. I don't mind. I feel I was put here to do this. I really do.
well, I it's really amazing and thank you for doing it because we need more people to be, willing to I think my favorite quote of the world, get comfortable being uncomfortable and
Hmm.
having conversations that not everybody's equipped to. And because of your background with the research and the academia, I mean, you obviously are a really great person to be in that space.
Thanks.
So with that, do you mind if I shift a little bit? And if I push a little bit, I think some of my viewers, they always want me to ask orthodontists, and they had me ask Dr. Kevin Boyd on
Mhm,
last episode. There's always this conversation about prefabricated, appliances and
mhm,
expanders. And, you have two beautiful girls. And if you could go back and you had a child, your own child right now,
mhm,
and you had your perfect little treatment plan of somebody, let's just use the example we are talking about in that 5-year-old with a cross bilateral, something along those lines. What would be some of your go-to structural method? I mean, have you utilized any of these prefabricated appliances, or you still like the traditional expansion? Just a little bit, and again, just a little bit of your philosophy and concept on that.
mhm. So I have come to the realization in this where I stand on this is we need to make sure we're diagnosing. Okay. So
Mhm.
we again, if we just throw a prefab appliance or a growth guidance appliance at a child who is 3, 4 years old and narrow, crowding, high vaulted palate, maybe developing an anterior open bite, not nasal breathing. If we just look at that patient and treat everybody with that type of appliance, we're no better than the orthodontist just straightening everybody's teeth. We're just on the other end of it.
Mm.
No different. You're just treating the symptom. It's important that you get to the etiology. So we need to look at these patients and find out why they're like this. Do they need ENT involvement? Do they need allergy involvement? Right? Do they need a release? Right? They have tethered tissue. Is it I mean, because maybe if they're just allergic, they're allergic to cats and they have cats, right? Then you can help. If we just start treating and throwing devices or appliances at people, I think that's where it gets tough. And that's where the orthodontic arena, to defend their side, they look at a lot of that happening out there where everybody
Mhm.
who's 3 or 4 just gets thrown this appliance. And that's why they say people are just doing this to make money. And you know what? I don't know how I could defend that because if you are just treating everybody's symptom, and not looking at the cause, then how do you point the finger at the orthodontist who's doing the same thing on the 12 or 13-year-old? That being said, I call on all sides to look at the etiology. Why is this child doing this? And if we can encourage that child to nasal breathe better, because the reason this child's growing this way is the mouth breathing. Well, sure, growth guidance appliances, prefab appliances can be a great adjunct for that. I hear a lot of people, the orthodontists, get really frustrated because there's other providers out there saying that the growth guidance appliances are going to prevent need for ortho down the road. You know,
Yes.
it's like I never even said I did amazing phase ones, and I'll talk about that in a second in an answer to answer your question. But I never told people it's going to prevent the need for future treatment. I said hopefully it'll
Exactly.
lessen the severity, maybe decrease,
Yeah.
maybe every now and again you get a patient it doesn't need. But when you're making that promise, that's where people go, see, they're just trying to pressure people into doing it, and then the kid needs comes to me down the road, and I'm just taking their word for it. But a lot of orthodontists will say those same patients come to me later and it didn't work as advertised. And now they've got to spend all the money with me and they're frustrated. They just spent money younger on it. So that's part of the issue we're having here. I think if we all can agree that we just figure out the why, but that again, it's a lot easier and faster, just like it's a lot easier and faster to pull some teeth that are crowded and put them in braces or Invisalign, right? And get
Mhm.
them in your system of your clinic to just keep straightening teeth. It's a lot easier and faster to see a younger child with those problems and give them a device and get them into the system of your clinic. It's a lot harder to take the time to try to figure out what the heck is going on here. And so I really believe that we need to look at the why, look at the etiology. When we get that, then we have to work with other disciplines. And that's another thing I'm working hard on, is trying to break down the silos. It's really hard and confusing because we don't learn in school. Like pediatric dentists don't learn how to work with orthodontists, don't learn how to work with general dentists. We don't learn that. We are so siloed. We are in the same building, sometimes on the same floor as these other people. And it's like there's a wall between us, other, not the literal wall of the clinic, but like a conceptual, intellectual wall. And we can't idea share, or maybe we get together
I
for a conference once or twice a year, but there's no
I did
routine.
not even know, like, you saying that for some of the listeners, like, I was blown away when I was in Vegas and I was at UNLV for a short period of time. Couldn't believe, like, I was like, "Oh, well, can't we just ask the ortho They're like, "Just
Like, oh,
ask the
just
ortho,
you
what
can't
are you
just go ask an
talking."
ortho, right?
I was like,
Yeah,
"What are you?" They looked at me like I was crazy. I was like,
yeah.
"Well, hold on, they're, like, right next door."
I
Like,
can
what do
see
you mean?
them, like, we
Yeah,
can't, right?
and then one day I think I, like, but I guess my ignorance being bliss, I, like, dropped off and I was doing a lunch and I invited both. And you would have thought it was
Oh,
like the two families, and they were like, "Well, oh, we're in the wrong room. Wait." And I was like, "No, no, no, you guys all can come in."
yeah,
You would have thought I blew it up. I quickly was not invited back after
right,
that.
yeah.
Yes.
Yeah, that
um,
it's true. That's what
I
it
didn't
is.
realize how
It's crazy,
separated.
but it's the way it goes. And so that makes it hard for whoever comes in to figure it out. And now you're telling them they've got to work with a myofunctional therapist and with maybe a oral surgeon or a periodontist or someone who's going to deal with a tethered tissue, or a GP, right, who does that, or a pediatric dentist who does that, right? They've got to coordinate that care. And now they've got to potentially take additional imaging on this patient to figure out why the patient isn't nasal breathing, and then they have to send to an ENT, and the ENT is probably going to tell them in a lot of areas that there's nothing we can do, or we'll wait, they'll outgrow it, right? We hear that all the time. So now you're kind of fighting the medical establishment, and then you send the patient for allergies, but the parents don't want to put through allergy testing. So you see what I'm saying? Like
Yeah.
it's a lot easier to just be like, here, try this thing. Like, and I'm not putting it down. I'm not saying it's bad for those people to do
No,
that,
no.
but
And
it's
I
like it's just
I
easier, right? I
I
mean, you were
asked
saying,
that
what's my
and I
ideal? My ideal is you go through this process with every patient, and I don't think we're going to get far until we do that.
No, and I asked that question because, my goal and mission is like I want to just help bridge the gap and help support the communication. And I'm always trying to tell the therapist and orthodontist how to have better conversation. And one of the things we talked about is that I'm all about activation, right? Like, don't just stick a structural appliance, get things moving and try to help the docs
Hmm.
so that you can help them get to their diagnosis quicker, so that maybe you could alleviate some of this big conversation so it doesn't drain their resources.
Hmm.
And I'm not like I always say, I love all tools, like, they all have a place and they all
Hmm.
need to know where to be used. And
Hmm.
I think in a way, again, not, listening to what you're saying is I think you're kind of saying the same thing. It really
Hmm.
does matter the why.
Yeah.
It's not and really the person using the tool and making sure they have a clear understanding of why they're giving it to you, what the expectations are.
Yep. And how to
And
use it. You talked about that on my show, how to use these things, right? The
yeah.
parent-patient education, which is your sweet spot. How you can't just throw these things at people, and expect them to work.
Yeah, and at the same time, when we go back to the across all of it is like, listen, patient education costs time and money
Yes.
is resources. And again, a lot of the listeners, you guys would be like, oh, Melissa and Dr. Mike are just talking about money, but the business is a really big
It's a
part of this.
business. It's a business. Yeah. I
And
mean,
medicine is part of it. And it's one of the reasons why we're fighting so hard to try to push the status quo, get people to think out of it so that we can figure out best business practices, right?
yes.
Best business practices. And somebody to say, listen, you have to do it even though it's uncomfortable and it's going to take you longer. We need it to come down from that aspect.
Yeah, we need to
Um,
push for greater reimbursement for diagnostics in dentistry. I mean, we're not paid to diagnose. We're we're
oh,
not.
and I mean,
We're
ortho
paid for procedures.
And ortho benefits, let's be honest, are like even if you have PPO, it's a coupon. They're not even
Yeah.
paying that right out of that. Like,
No.
there's such a I wanna say I think people are quite delusional sometimes, even when it comes to their ortho benefit. I was
Yeah.
like, the insurance company is stacking up against you here. It's
Oh,
not
completely.
like,
Because they make it seem
no,
like
but
it's just cosmetic, and we've fed into that problem. We haven't fought them back on it, which is why I'm
well,
saying
I
this is gonna be a bigger fight to try to get them to understand because, they hit the Saltzman index, they call it a handicapping index. It's not just about handicapping occlusion, it's about a handicapping aesthetic result too. So if the teeth are at a point where they think that that person will have a greater ability to thrive in society if they are helped orthodontically, that patient will get coverage if they're on state funding or an insurance company. A lot of insurance companies now do, sometimes they have a medical necessity rider on there. So you have to prove there's a medical necessity to treat this patient, even in the private pay world now. So when it's a very fair point you make about it coming down to the money. Name an industry of medicine, dentistry, podiatry, ophthalmology, optometry that the treatment doesn't follow the reimbursement. I mean, come on, let's not be naive here. I mean, it shouldn't.
for
It's not what we should be doing. But I think part of the reason we got down this whole problem where we need a Maha movement and people to stay like, wait a minute, we're just treating, and everyone's getting sicker and sicker and sicker. Well, why? Because the insurance companies, I mean, CPAP, when did CPAP become so prominent as the way to solve OSA? When insurance companies started paying for it. And I think the 80s or yeah, this was like 80s.
yeah.
Dave McCarty was on my show and was talking about that and was just brilliant on that stuff. So it's like, when did that become a thing, right? Well, when insurance companies start, why is OSA still the thing we cling to? Because that's
Oh,
what reimbursement is based on. Like,
ab
I I mean, I think we're just saying the things that people are like kind of, you know,
you
might say
know,
in
the
private, but like we're just,
part of
I'll
patient
say it. Like I'll say it. Yeah.
Same. I had a patient yesterday who is an adult patient, works for the insurance company, works for the medical insurance company. Okay. She needs jaw surgery, absolutely handy, sleep issues across the board. Every aspect she knows what it looks like. They came back and said she hasn't been on CPAP enough to prove that it's not working before they'll pay for it.
There
The
you go.
woman, she's paid for, she's had a sleep endoscopy, the whole nine across the board. And again, she's like, I'm not going to do this surgery. I know they can pay for it, but they're like, nope, you got to do more CPAP. You got to do more CPAP.
Right.
Then come back, do another mandibular advancement appliance. Let's make sure that fails
Uh,
before we agree. So again, not, again, I know this can sound very negative and overwhelming and not very positive, but being able to have these conversations allows, I think, other people to be bigger advocates for themselves and
mhm.
their own health. And I always really encourage parents, the number one way to fight back or to kind of get through. And I think as an orthodontist, if you have a parent and if you when you were in practice, you have a parent that comes in and is like, hey doc, I'm here because I know that there's something bigger going on with my kiddo. And I will, I'm good if the teeth don't look great afterwards. If you got to do it twice, I'm okay with all of it. Are you willing to help me out? Are you willing to play? I do find that some are a little more open when the parent kind of takes away the pressure of the
Mm.
orthodox
Oh,
of like
sure. I believe that.
hitting. Yeah, I don't.
Yeah.
Right, I'm thinking if, if a parent says that, the doc's like, "Alright, well, I mean, the parent's saying they're not gonna hold me responsible or they're taking away that liability." Maybe that almost, like, loosens the handcuffs a little bit of
Mhm.
just, curious of what your thoughts are like with that tactic because that's how I try to teach the therapists in my ortho course and stuff is like educate these parents, teach
Educate.
them educate the parents, and I want every myofunctional therapist that's the whole reason we do the things that we do is I want them to be able to hold their own in a conversation. I want them to walk to an orthodontist or sit at that table, know the names of appliances, know the
Mhm.
concepts so that they can't get dismissed right away,
Yep.
right? Like,
Yep.
'cause I do think in our industry, being able to hold
No, it's
hold a
true.
certain conversation matters. So I don't know if you agree, so I appreciate, yeah, what your take is on that a little bit.
Yeah, the education is huge. It's huge. That is how I did it. That's how I did it in because remember, I all of a sudden was telling people we're going to treat well before this was discussed, well before there was social media groups, mom groups talking about airway and ortho and early treatment. Like I was doing this. I mean, I was actually doing this 20 years ago, not knowing what I was doing at that time when I was using upper and lower fixed expanders in the mouth in young kids. It was just doing it because I realized that patient B, that the problem wasn't big teeth in patient B, that the
Mhm.
problem was actually narrow jaws. And there's studies on that. McNamara again has a study on that. It was 83 in the AJO on that concept of looking at what causes crowding. Crowding is almost always caused by narrow jaws, not big teeth. So I recognized that, and I was like, okay, well, if it's narrow jaws that are the problem, I'm going to grow the lower arch, not the mandible. I'm going to upright those lower teeth, and I'm going to expand the maxilla. So I was doing that going back 20 years ago, but I didn't have any idea about airway. None. None. And parents would sometimes be like, Dr. Mike, do you think like it's a thing that maybe this is tied into how they're sleeping? Because I swear they're sleeping better. I'm not hearing them snore anymore. Or, they're like, when I wake them up in the morning, they're not, they didn't toss and turn as much at night. And embarrassingly, I was like, well, I guess it couldn't hurt. Like, I mean, I've seen some studies where, expansion can help airway. So I knew it was kind of a thing, but I didn't really realize what I was doing. And it wasn't until I started anyway, the expansion, another reason why orthodontist, to your question of the ideal way to treat, another reason we don't like to do this, putting upper and lower expanders in, let's just even say 6-year-olds at this point, it's not easy to do on young kids. It's gotten easier. When I did it, back in my day, you didn't have digital or 3D scanning, so I had to fit the separators. You'll
Oh,
recognize
yeah.
this, right? Fit
Uh-huh.
the bands. Yep, you know it.
Yep.
Back in, yep, you know. So we would do this, and it was very time
It's a lot of
consuming.
manual labor for any of you guys
Lot of
that don't
manual
know.
labor, pouring these things up and pick up impressions and a band shifts and you had to redo it. I mean, a lot of work and time on your team and on your patients for your patients too and parents. And so I was doing this thousands of cases this way over 6 years or so. I mean, thousands. And it was working. I was getting pretty decent results. I was getting pretty decent arch development and space on these patients overall, but they still needed a pretty healthy second phase in a lot of these cases because turnkey expanders aren't very precise. They're kind of a macro approach, right? You're just kind of pushing everything out. I mean, you're just literally
Mhm.
pushing everything out. It's the design of them. But it was better. I wasn't having to pull teeth. I wasn't noticing. I was still having some problems with the canines getting impacted, but it was definitely better. And then I realized there's something going on here. There's something with the airway, and I can do things differently. And that's when I got my cone beam and I started understanding like I'm making a difference in how this child breathes. I'm looking at pre and post CBCT images and I'm noticing tremendous change in these patients' airways. And I'm now asking the right questions in my diagnostic conference. I'm now educating the parents on the importance of nasal breathing. I'm starting to tie that all in. And Melissa, the conversion rate, the people understanding it and call instead of me trying to convince these people that like this is a good thing to do for their kids so we don't have to pull teeth, because that's really what I thought it was at that up to that point. Now I'm saying I can help your child potentially. I never promised they would breathe better, but I would say that this is going to by normalizing their anatomy, we're increasing the chances. There are
Yeah.
plenty of studies to show that when the arches are narrow and constricted and there's not enough tongue space, that child is more likely to be a mouth breather and ultimately snore. So I would be able to say that. And now the patient starts to realize, oh, wait, this isn't just about straightening my kid's teeth twice, because that's what they think two-phase ortho is.
Mhm.
It's about the first phase helping normalize the growth and anatomy of my child. And then if it based on where the teeth come in, we may need to do some perfecting and get things to line up just right. That patient education was huge. And then when I made the switch in like, it was like all happening 2011, 2012-ish. And then my cone beam came just after that. But I realized I could do this without using turnkey expanders. And that's a lot of what I teach that now, significantly, is you can do this. I literally just had a coaching call with a doc, a general dentist in New York that I teach this to, and he's killing it. He's doing amazing. He's had a year of it, and he shows me his cases. They're amazing. And I literally just told him, like, you're going to come on the road with me one day and show. He had no knowledge in orthodontics, none. No, he did some
Really?
Invisalign for adults a little bit, but never had used braces, nothing. And he is now putting full braces on 6, 7, 8-year-old kids, which I've taught him to do. And you can get skeletal orthopedic expansion of the maxilla in young kids without a turnkey expander. Hard
Really?
stop. People don't
Hard
think
stuff.
yeah, the data are all there. Yeah, it's not even, it's called the infantile suture. Burt Milson had a study in AJO in 1975 that showed this. The suture's wide open and patent. And there are studies in the 70s and 80s that show that all you need is, some studies say as low as 221 grams. That's like half a pound. That's not much. Most studies are like around 400 grams, which is a little less than a pound. That amount of force is all you need in a young child, not a 13-year-old, to get orthopedic change. And I have this pre and post CBCT images to prove it. But they took radiographs. They showed sutural separation on young kids. Back then, they weren't using braces and wires. They were using what's called a quad helix or a W arch. Same
Mhm.
force, though, same force magnitude, about 400 grams. And so 70s and 80s, Ricketts in the 70s, and then Bell and Chaconis, and all these people were putting all these studies out. It disappeared in the orthodontic literature that we don't do it anymore.
Mhm.
But that made it so it was easier for me to deliver it, because it's not super easy or profitable or fun to put upper and lower turnkey expanders in all these young kids, all the emergency visits, all the tongue ulcerations, all the speech
Mhm.
problems, all the feeding problems. I saw it all, right? It's not fun. It's a lot of work on everybody's plate. When I went to braces and wires, and it took me a couple years to figure out how to exactly like dial it in. And that's why I now built a course and I teach it. But it's amazing for myofunctional therapy. You guys love it because nothing's by the kid's tongue. You
Yeah, I was
could
just
start
gonna say
therapy day one. Yeah.
you're leaving that whole space open.
Yeah, it's
Well,
so
I
great. It's so great. So that would be my ideal to close with my, if it was my daughter,
thought
own
or something
daughter,
that you would use.
that's how I would approach that case, and then watch them grow. It takes usually a year to year and a half to do that. Make sure all the teeth come in. You get these beautiful broad horseshoe shaped arches, beautiful tongue space. They look good, really good, which is kind of cool when an 8, 9-year-old is so proud of their smile at that age.
Yeah.
Why we don't talk more about that, I don't know. But yeah, and then I'd watch them grow, and we give them little clear retainers to wear full time for 3 months, then nights only. They'd eventually outgrow them. We educated the parents that they would eventually, when they got all their adult teeth in, they would outgrow these retainers, and we would look at any need for any future treatment. And then if they needed treatment, because some didn't, actually a decent number didn't, but I never promised that, we would just go in with Invisalign or braces for, usually it took a year, sometimes, year and a half if they had a
Just a
small lower
little pick
jaw.
and fence,
Yeah,
just kinda
and
line
yeah,
things up. Mhm.
exactly. Line things up, and the structure's all looking good. You're not pulling teeth. You don't have impacted canines. It's unbelievable. It really, really is unbelievable. And I show hundreds of cases in my course on this. I mean, it's not just, once or twice it works. It works, but it's not the way people were trained to think. So it's hard to change, as we started by the conversation by saying.
So with that, just a little bit about the business, right? With the coaching business and obviously the
Mm,
courses that you're up to. Who are some of your ideal, like, type of clients or potential coaching clients come out? I get a lot of docs that are coming to me that are always like, so one area I'd like to go to is that one place I have found that you'll get a couple docs that are really interested and they get a little overwhelmed of like where to even start in this
mm.
world, right?
Oh
Like,
yeah. Yeah.
do I go dive into a tongue tie course? Do I
Right.
take a Myo 13, 12-week course? Do I got to go to all of these things? So one of my recent missions has really been to create something like a real dip your toe in, just info, and
Mm,
always looking to build. My goal in life is that every team has a base understanding, their front desk to think to at least screen and identify for airway.
yep.
Whether they do anything, they can send it out, right?
Yep.
So I'm always thinking of like, what would be like if you even could think of it like first start, like if what would be the first course if a good friend of yours came to you and said, Hey, Mike, where do I go? Like, where do I even start to even see if this is something I'm even interested in? Is there any of your favorites, or is that something you're leaning into with your coaching or hoping to tap into? I'm just always curious, like what tracks different docs in our space are sending people or coaching them themselves.
Yeah, I would start by trying to listen to different podcasts of people in the myofunctional therapy arena, in my arena, in the orthodontic arena, who and dental arena, who are talking about this stuff. I think you have to expand your reality a little bit first to understand what you're even looking at, because it can be so
Great
overwhelming,
point.
right? You got to
Mm,
kind of think like, okay, and realize that there are going to be people who are going to also be like, everybody needs a release. And then people who say no one needs a release. And then people who say everyone needs a growth guidance appliance and no one needs one. So it's really hard to distill that down and to analyze that logistically, to say like, what the heck is the truth?
mhm.
And there are going to be people who say mouth breathing is no big deal, and people are going to say mouth breathing is terrible, and it should never be happening. So I would say start to just educate yourself. And there is a lot of free content out there. Your platform, my platform, I have tons of free stuff to for people to
Mhm.
just start to learn. There are a lot of groups out there who are giving courses on this. So there are a lot of providers who you can start to just pick their brains and go online and start to read some of the data. Be wary of someone who's just showing like a case and selling a product. I always say that
Yeah,
because
for sure.
I right, because it's like, I'm not faulting it. Like we all get sold products and buy products all the time, and we're all selling our own product in a sense with what we do. But if it's just about like, hey, everyone should have this device, and we talked a little bit about that on our show when you were on my show, like if it's just like everybody should have this device or everyone needs this, I think you need to be cautious of that. And then I would try to find somewhere where you can get educated on the negative effects of mouth breathing, which is going to be part of what I'm going to try to address in that rebuttal, and start to see how the way we breathe can affect the growth and development of the face. I really feel like if you don't understand that first and foremost, it's like trying to build a house if you don't understand how to pour the foundation. Like
Mm,
you could probably build a pretty nice house, maybe you're the best at framing or whatever it is. But if you don't understand how to build that foundation, it's not going to have the ability to withstand a storm. And you
no.
need to know how to build that foundation. And that foundation gets to the education and the data. And that doesn't, again, mean a randomized controlled trial, evidence based, as academia likes to call it. It's not that. It means the best available data, which could be not a randomized controlled trial. That's kind of the best of the data, but not everyone, they don't exist in everything. And that's okay. It doesn't mean if there's not an RCT, you can't do something. That's not a thing, as much as we get told it is. You just try to understand that this is what is happening. And then do the diagnostics on your patient. And I honestly believe, Melissa, the more you start to look at your patients critically, ask the sleep questions, look at the tongue tie, look at the motor function, ask the personal history questions. Have they been to an
Mhm.
ENT? Have they been to an allergist? Do they suffer from chronic congestion? If you can, invest in a cone beam machine, CBCT machine, to start to take you can get low dose images, less radiation than 2D. Many machines out there will do that now. Less radiation than a pan and a ceph. You can take a cone beam and you can start to look into the nasal passageways, pharyngeal airway, get cross sections. So you look at a coronal slice of this patient's arch, and that patient B we talked about, you'll now notice in a CBCT that the palate is high and vaulted and the lower teeth are caved in. You need to start with the fundamentals and build that foundation of knowledge. And then the treatment and the solutions start to become more clear. Am I
Which is
saying that in a
great.
way? Because I think if
Yeah,
you just jump to the treatment and solutions, you don't
yeah,
understand what you're doing, and then you look at the next thing, you're like, well, wait, oh my god, did I miss a tongue tie? And you just start
yeah.
to chase your tail in this.
You couldn't have actually really brought it back full circle any better than that, because the truth is like it's all about screening your own
Mhm,
patients, and
mhm,
actually starting to believe and connecting your own dots. Because even when we go back to what we started with, like you got to create a feeling, you got to start to hear it, believe it, see it, not just jump to, what you're telling someone to do or what this solution is or this one. You need to look at your patient population, your team, your
mhm,
group, and really ask yourself, okay, where do I see myself in this? How does it all connect? And I think that will let people be a little more open to actually, yeah, you got to believe it to see it, and the best way to do that is to screen it. And
yeah,
you got to
that's so
screen it,
true.
and I'd be able to identify it and then start having conversation. I think after that, it's like anything. Once your awareness is built up, you kind of can't deny it anymore. I mean, it's like any 12-step program. Then the first thing is you got to admit you have a problem.
Yeah, you
You
gotta
know,
acknowledge it, yeah,
you
yeah,
got to
and that's such a
acknowledge.
great point, talk about tying it together, because that's what we were talking about with the orthodontic community before. They won't go to step 1. And so I've realized that, like, if I can't get them to
Mhm.
acknowledge the problem, I'm never going to convince them that they need to do something different. Never.
Which, I mean, if we kind of almost just take it to this, maybe almost kinda ended here in a way, is that between my community, your community, and when we say that myofunctional therapist or parents, or for me, I've been lucky, I've a lot of alternative health providers, because I really do see that mental health connection so close with the behavior aspect, which
Mhm.
is another really big thing, which is actually also another really frightening aspect. Is
Yeah.
I don't wanna open up a can of worms that I don't feel like I'm equipped to even go down or discuss.
Which was not even mentioned, by the way, in that article that I was talking about, that editorial. Nothing about the neurocognitive. 0,
The
because
neuro
he
and
doesn't know.
and I am, like, living proof. I mean, that's why I open up about my story so much, is that, I mean, my mental health is 150% connected to my teeth, the way I sleep, every aspect of it, my
Mhm.
child, and when you start to once you start to feel that and see it, it's undeniable, you can't
Mhm.
really get past it, and so when we think of that, I people will say, "Well, what do we do?" And I said, "Well, you keep having conversations, and you keep kind of going to great lectures, you keep going to
Mhm.
conferences, and you support the cause, and you really don't just accept
Yes.
somebody saying no. You find the next person, and you keep going, and I think the more we do that, the more we keep growing, and hopefully we'll continue to push academia and the status quo, and we'll
Mhm.
see change, but it doesn't stop by just accepting it. You gotta keep pushing through with that. So, I mean, you are at this point, right? 100%. You are podcasting, you are lecturing across, doing your courses. So a lot of the viewers, they can find you all over the place. So you mentioned in October you're going to be at Airway Palooza. Is there any other upcoming? I'm sorry I'm telling you, pull up your calendar. I didn't mean to throw that. I'm totally
Yeah,
going rogue. This
I
is
might have
totally
to.
rogue.
No, I do know it's, yeah, it's quite busy. I'm going up to Georgia and Atlanta. There's a multidisciplinary group up there that is run by an oral surgeon, and they reached out to me to come give a course at a multidisciplinary study club they have. And then the following morning, I'm actually, which is this is kind of exciting, I had a group of orthodontists who heard I was going to be up there for this other lecture, and they reached out to me for a small Atlanta orthodontic study group of like 15, 20 orthodontists that are going to bring me in to speak the next morning just to them. So that's
Oh, wow.
progress. Yeah, that there's this group of orthos that want to hear more about what I'm saying and teaching. And I love, speaking to I mean, I speak to all different types of groups of professionals. So it's nice when there's a group of orthos only like that I can dig in a little deeper and help them answer some of their questions that we've talked about on the show. And then I'll be in October. I'm going to be going to Dr. Jennifer Buchanan is an orthodontist in Texas. Are you near
Yeah.
her? Okay.
Yeah, yeah,
Yeah,
yeah.
I'm going in. She's going to bring me in to be the speaker for a CE event she's holding for her referrals and community docs in her community.
Amazing.
Yeah, so I'm going to be giving a talk there for that, and then I'll be speaking at Airway Palooza, and then I'm giving a lecture which is in Fort Lauderdale, and then I'll be giving a lecture in November in South Florida as well, and then I've got a few lined up in next year, and I was actually invited to speak at the Florida Association of Orthodontists and be one of the speakers there, which again, big step forward because a lot of these orthodontic only groups have tried to not invite people such as myself or who talk about things like I talk about there. So we're getting there. We're starting to penetrate into that shield and starting to break through that armor a little bit at a time, a little bit at a time. But yeah, so I love speaking and I love bringing a message to my audience and it's what I love to do. So
Well,
yeah,
it's
so
really exciting because it does definitely line up. We are working really hard on building out a real myo that's based solely for
cool.
orthodontists, and working on I'm doing that, and, as soon as we have that launched up, I'll make sure I give you a sample of that so you can take a look and maybe give your listeners a little preview of that. My goal is to meet the orthodontic community where they're at and make myofunctional therapy something that makes sense in their world,
Hmm.
and,
That's great.
we're down in Florida a lot too, so hopefully we can cross paths and send some stuff that way, because we do want to close the bridge, right? We don't want to make
Yes.
more obstacles, and I think if together, I know from my end of the Myo community, I keep telling them, like, we do have to meet them in the middle, right? We have to give in a little bit. We
Yep.
can't
It's
we
a great
can't say,
point, Melissa. It's a great point.
we do, because I can't ask a bunch of orthodontists to just do it my way and vice versa.
Yep.
So I'm going to push the status quo and just come up with something that's really digestible that, some of these docs can just include in some of their early that,
That'd be
because
great.
I love, Gary Vee says sometimes just give it away and they'll just keep coming back for
Yeah.
more.
Yeah.
And I think the ortho community would be greatly appreciative if we just don't keep adding more roadblocks. And
Mhm.
I just try to push both communities to say, it's a good negotiation is when nobody thinks they won. It's more of like everybody kind of gives in a little bit. And I
Yep.
think the bio community can do the same.
Yep.
So I think we can take it at that, is like we are still pioneering and pushing things through. And we just kind of leave things on this podcast in a little bit. If there was, the one thing that keeps you optimistic for the future or that you'd like to leave forward, where's your headspace at? Is there something that like is really exciting you, or like that you're feeling really great for that, we can just leave on a positive note as we wrap things up?
Yeah, it's taken even beyond just teeth, really, and the conversation of the orthodontic side. Just the life decision I made when I transitioned from my private practice to this arena wasn't easy, but I did it because the amount of time and energy that my practice was taking out of me, very, very open talking about this on my show and as a guest on other shows, was quite onerous. I had built something that was really big and I was proud to build it from nothing. That being said, it was taking a bit of a toll and I wasn't able to be present for my family the way I needed to be. I was physically present at most things, but I wasn't emotionally present the way I
Mm,
needed to be. And you get in it, and it's hard to realize that I wasn't being good about my sleep hygiene. I always was working out and staying healthy from that perspective and from a diet's perspective, but I wasn't sleeping enough and was just not at a level of I was at a level of stress that really wasn't healthy enough. And so the past 4-ish years as I kind of transitioned out of private practice and into this role, I've been completely immersed in this role for about 2 now. It's really been nice to be able to be a dad to my daughters, a husband to my wife, be around and able to be present for them and at their events and spend time with them because it ends. And it sounds really cliche and corny to say, but now that I have one in college and one on her way soon, it ends. It ends. And I know it's crazy when you have little ones running around and it seems like you're never going to end. My youngest one now has her driver's license, so you're not even like driving kids around anymore.
no.
It's crazy. So to everyone out there who has little ones and it's stressful and it's hard, work will always be there. They will be gone out of the house sooner than you realize.
Yeah.
And take the time, build the foundations with your family, with your values, if that is what you value, with your friends. If you don't have family members and you spend time with friends, don't neglect all of that just for work because you have a lot of years after those people are out of the house to work. And so I'm blessed and fortunate that I made that change when I did because I definitely wouldn't have the relationship I have now with my family if it weren't for that. So that would be what I would encourage everybody to do.
Well, I can't thank you enough. Thanks again for spending some more time with me. This was great. I look forward to definitely chatting with you again. And we'll make sure we put everything in the show notes for everyone to get in contact with you. But real quick, where's the best place for everyone to find you?
Probably a website is DeLuke Orthodontic Coaching or theorthocoach.com is the name. The name of the company is DeLuke Orthodontic Coaching. But if you go to theorthocoach.com, YouTube is at DeLuke Orthodontic Coaching. Instagram is at the Ortho Coach, although I'm not the best at Instagram. My older daughter, I'm like, gee, you're gonna have to help me. It's
I
just not. I don't like it. I know I got to do it, but and I actually started a doc community on Facebook about a year and a half ago, I think, and we're about 800 members now.
Yeah, it's a
And
great
so,
place.
yeah, there's some. It's open to any dental professionals. I haven't opened it up to laypersons yet, but a dental professional, or they could be myofunctional therapy, speech, hygiene, just to start to talk about the things that are more taboo in our own respective groups. We can kind of have one place that it's a spot we can talk about this stuff in a more open forum than you may be able to do it in your particular group outside of that. So yeah, and or people can email me, Dr. Mike at theorthocoach.com. Feel free to email me. I don't mind.
Well, thank you so much for your time. We appreciate it. And we will see you guys all soon. Thanks for joining us.